We sure are. Looks great.
Wonderful. So much easier when I only have my one monitor. It works easier. Good morning, everybody, and thank you for the privilege of sharing a case. And what I would like to title in complex stable coronary disease. To have the goal of improving left ventricular systolic function. However, the randomized clinical trials to date have demonstrated that PCI in the presence or absence of myocardial viability or surgery in the presence or absence of myocardial viability often disappoint in the explicit goal of improvement of left ventricular systolic function. Occasionally, however, we are pleasantly surprised. So we had a heart team approach, and so we convened the patient's physician, CT surgeons, interventional cardiologists, and we collectively felt that due to severe distal left main disease with a 111 Medina classification and the profound left ventricular systolic dysfunction, that we should get everybody's perspective. And we generated the syntax 1 score, and that was 34. The syntax 2 score predicted a 50% mortality if treated by PCI and a 27.5% mortality if we treated the person with surgery. However, the comorbidities that were not present in syntax and the overall patient's social construct led us to recommend high-risk PCI. We'll talk a little bit more about that. Now, if we take a look at the American College and the American Heart Association and SCI guidelines for revascularization, situations in which PCI or CABG would be preferred in the setting of complex disease, there's a class 1 recommendation that in patients who require revascularization for significant left main disease with high complexity CAD, it is recommended to choose CABG over PCI to improve survival. And a 2A, that in patients with multivessel disease with complex or diffuse and a syntax greater than 33, it is reasonable to choose CABG over PCI for a survival advantage. Secondarily, in the presence of left ventricular systolic dysfunction and multivessel disease, which applied to this patient, class 1, that CABG is recommended to improve survival. Class 2A, that CABG, including edema, is reasonable to improve survival. And that in left main disease with stable ischemic disease, CABG is recommended to improve survival. Class 2A, in selected patients, that PCI can provide equivalent revascularization to that possible with CABG. And then critically, that at the time in 2021 that these were published, that in patients undergoing stent implantation, IVUS can be useful for procedural guidance, and that can be with either OCT or IVUS. And if the patient had prior PCI, that IVUS is reasonable to determine the mechanism of stent. As well, that in selected high-risk patients, elective insertion of an appropriate hemodynamic support device as an adjunct may be reasonable to prevent hemodynamic compromise during PCI. And this is based on, the high-risk PCI trials that demonstrated that the use of Impella over IEBP or medical therapy resulted in less hemodynamic instability during procedures. So the party line, as I would state, are based on the following clinical trials: Syntax, Freedom, Excel, and Noble. And if we take a look at Syntax that enrolled patients now over 20 years ago, this included patients with 3-vessel or left main disease, and noted that CABG was better for high Syntax scores and PCI for low. Freedom, which included diabetics with multivessel disease, demonstrated that CABG was superior for both MACE and mortality. And then the 2 left main trials demonstrated that PCI in Excel was non-inferior to CABG at 3 years, and Noble showed higher rates at 5 years. So this is abstracted then by the clinical guidelines that state CABG is preferred in diabetic patients, patients with complex anatomy, and reduced LV systolic dysfunction, and that PCI is reasonable in non-diabetics with a low anatomical risk score, high surgical risk, or patient preference for less invasive. Now, it's interesting when we look at these trials and we look at Syntax. Syntax showed a 28% relative risk reduction, but it was driven not by a reduction in mortality, but by a decrease in subsequent myocardial infarction rates and repeat revascularization. Intracoronary imaging was not used, and often complete revascularization was not attained. Freedom certainly demonstrated an increase in MACE by about 9%, with a reduction of CABG conferring reductions in MI and death. And then in this high Syntax score, it was again a decrease in MI and repeat revascularization. Intermediate, still increased benefit of CABG, low syntax equivalent. And then for the Excel and Noble, it really depended on the anatomy. And so this is the totality of the evidence that the guidelines that I shared with you state. And they were primarily outside of Noble and Excel, not included intravascular imaging, and plaque modification occurred in less than 3%. That is, almost nobody got rotational atherectomy. And certainly during these trials, intravascular lithotripsy did not occur. And again, incomplete revascularization was frequent. So I've shown you the data, but this is actually my perspective as I look at the totality of the evidence. Our goals for a given patient should be to attain complete revascularization, number one. Number two, given that we're talking about complex coronary disease, we should use intravascular imaging to guide how we do our PCI and what the outcome of our PCI is, and I'll talk about why. It's critically important that we involve our patients to choose what is right for them, and that we participate in a heart team to achieve collective perspectives that will then inform how we approach our patients and help our patients arrive. And then finally, we've got to use aggressive secondary prevention with appropriate use of SGLT2 inhibitors, medications to reduce obesity, high-intensity statins, and antiplatelet agents. Now, what do our patients want? They want to feel better. They want to reduce their risk of a heart attack in the future. They certainly don't want to have stroke or pain as part of their treatment. And they'd like a rapid recovery to decrease dependency on others and return to a vibrant life. And they want to minimize the financial impact of missing work for a long time. So in this case, the heart team discussion thought that the patient, despite the differences in the syntax 2 predictions, would be better served versus high-risk PCI. As opposed to surgery, this patient was a primary caregiver for his wife and had limited social support. So let's talk about how we would approach this. And these are a list of features that increase the complexity of coronary disease. Left main or proximal LAD disease. And how do we mitigate these? By using intravascular imaging to guide what we do, appropriate lesion prep, and to assess the outcome of that lesion prep prior to putting in the stent and then following stent implantation. Secondarily, chronic total occlusions, we will now stage as a second procedure in an effort to attain complete revascularization, and overall success rates should be about 85%. Trifurcation lesions, we will talk about in the context of how we approach bifurcation lesions that are complex. And calcification will be determined by intracoronary imaging, and we must determine whether we should rotablate, do orbital atherectomy, or IVL. Tortuosity is the appropriate use of wires and balloons to prep the lesion in an effort to deliver the equipment, which might use mother and daughter techniques with guideliners. Aorta osteostenoses, there are wonderful techniques in how we image in the appropriate planes to make sure that we do not miss them. And then diffusely diseased segments are often best dealt with rotational atherectomy and balloon inflations. Thrombotic lesions selectively with aspiration, and lesion length of greater than 20 millimeters. Make sure that you lesion prep and stent edge to edge to normality. So in this particular patient, we want to make sure that in each of the primary Medina components of the 111, at the end of the day, that our left main attains a cross-sectional area of 12 square millimeters, our LAD 8, and our circumflex approximately 7. And when one does this, one is able to reduce the 5-year MACE events, including myocardial infarctions, from about 20% down to about 6%. This is critically important because if you do your PCI correctly, you can reduce spontaneous infarcts in the future. And so when we go back to that table of evidence that I showed you, that the guidelines are developed, that was not in the period of optimal PCI. And so again, predictors of 5-year MACE are markedly reduced by the cross-sectional areas that I mentioned, and making sure that we do not have stent under expansion at the ostia is critically important. And this is data out of the Renovate Complex imaging trial that showed if you optimize your PCI by plaque modification and adequate stent expansion, you can reduce target vessel failure rates and myocardial infarctions from 14% to 6.5%. And so these two trials that I just demonstrated show the importance of ideal stent expansion in an effort to improve that 3 to 5 year outcome. And I would submit decrease the advantage of CABG. The completeness of revascularization, if you look on the left at the red, this is what we call the residual jeopardy score. And if you don't completely revascularize and have a jeopardy score of greater than 4, you can see here over time, through 5 years, a MACE rate of almost 40% as compared to approximately 18 to 20%. So stent optimization via appropriate plaque modification and ideal complete revascularization of the major vessels are both critically important to improve long-term outcomes. And so coming back to this case, repeat echocardiography demonstrated persistent severe LV dysfunction, no clot. And so we elected, given profound LV dysfunction and left main and multivessel diffuse disease, to do high-risk PCI with Impella support, along with a plaque modification using rotational atherectomy, adjunctive IVUS, and then bifurcation stenting of the left main, LAD, and circumflex. And so in this case, we fall on the left. It's a left main Medina 111. Side branch lesion was greater than 70% and greater than 10. So this defined complex. And we had a 2-stent strategy with a DK crush technique, along with intravascular ultrasound imaging for this case. And when we look at a complex lesion, and this is an illustration on the right of our patient, one can see that DK crush was superior to provisional stenting with a 11% reduction in 1-year target lesion failure. So this case is clearly a upfront 2-stent strategy. And so looking here, we used a XB guide, Impella, and our intent was to deal with the circumflex, which is a side branch vessel, and come back and pay attention to the left anterior descending. So we used, the 7 French EBU 375. This would allow simultaneous balloon and or stent positioning if we needed. We wired this with a run through, and then using a Corsair microcatheter switched for a rotofloppy, and we performed rotational atherectomy of the mid circumflex. Following that, we stented the mid to proximal with a 275/38 onyx frontier and dilated to 3¼ at high pressure. We then placed a second run-through wire into the LAD and pre-dilated the mid to proximal LAD with a 2.5 NC at high pressure and did rotational atherectomy of the LAD as well after we removed the wire from the circumflex. And our standard is to do about 160,000 RPMs, try to minimize decelerations to 5K or less, and slowly advance, pull back, advance, and pull back, a modification of the pecking technique. So after we exchanged the rotofloppy for a workhorse wire, we then stented the LAD proximal to mid-segment with a 275/38 onyx frontier and dilated with an NC high pressure at 3.5 millimeter balloons for adequate. We then turned our attention now to the distal left main, ostial LAD, and ostial circumflex. And you can see here that we have the EBU guide, and we have a stent, which is a 3018, in the ostium of the circumflex, overlapping into the proximal segment in an overlapping technique with that proximal to mid stent. And you can see that the stent protrudes into the distal left main. And so again, this was going to be the crush approach. You see a balloon sitting in the distal left main to the LAD, and we, on the left, deploy the stent. On the right, we crush that stent against the ostium, and then we are going to recross the circumflex with a run-through wire and try and cross in the distal stents of the ostium. And we expanded that with a 2.0 NC, followed by kissing balloon techniques. There are some people who would have simultaneously deployed both stents and then come back and recross, but we chose a sequenced approach to this DK crush. And then we removed the circ wire and stented the LAD from the left main, overlapping the prox LAD with the 3520 Megatron, and then proceeded with recrossing and both a POTS and kissing balloon to adequately create the neocarina. And then we proceeded with POTS optimization with the 5.0 NC in the ostium to shaft of the left main. And finished with IVUS, which shows us, this is IVUS from the LAD coming back to the left main, and you can see good lesion prep, cross-sectional areas. Now we're coming into the distal left main. You saw the circ between 2 to 3, and good expansion without dissection. And so we were achieving a left main cross-sectional area of greater than 12, LAD of greater than 8, and circ-os of greater than 7 square millimeters, consistent with that reported trial that came out of, I forget whether it was a Noble or Excel. And so final angiography showed that the left main had no significant residual stenosis. The proximal to mid, LAD, and circumflex looked good. And then we're still left with the diffuse distal disease, which we did not address in the mid to apical LAD and the distal circumflex. This is simply an orthogonal view. And we had pre-closed with two sutures at 10 and 2, and were able to attain hemostasis without any complications of bleeding or limb ischemia. And the patient did well. So in conclusion, it's important that we participate in shared decision-making with the patient. Incorporating the heart team approach is essential. Equally essential is if we are going to do PCI, that we must completely revascularize the patient, and we must optimize, as we did here, our techniques by combining intravascular imaging to guide plaque modification when required, in an effort to improve stent optimization, and thereby, as I demonstrated, reduce MI, repeat revascularization, target lesion failure, and likely death. It doesn't stop there, however. We must have aggressive secondary prevention with ideal antiplatelet therapy, LDL lowering therapy to less than 55 in these patients with extensive plaque, and appropriate selection of SGLT2 inhibitors and GLP-1 receptor agonists as indicated by their comorbidities. Syntax score may predict risk driven by recurrent revascularization and MI, but ideal PCI, complete revascularization with a residual J-score of less than 4 and secondary prevention should reduce the risk to at least similar to that of CABG and allow our patients to recover more quickly. So I just wanted to share with you the guidelines and the basis of those guidelines and why our practice today with modern PCI should obviate and negate some of the advantages traditionally that CABG have had over PCI in stable complex disease. Thank you, and I'd be happy to take any questions.